Hello, everybody. Welcome to the podcast. My name is Brent Kramer. I'm one of the anterior segment surgeons at Vance Thompson Vision. I work in Sioux Falls, South Dakota, and Alexandria, Minnesota, and I'm joined by a couple of our other docs here.
Hi, I'm Doug Wallen. I'm optometrist at our Sioux Falls, South Dakota location.
And I'm Daniel Trevine. I'm an ophthalmologist in Sioux Falls, South Dakota, and I'm excited to be here on this podcast with you guys.
I love it. All right, so today we are going to talk all things, maybe not all things, but most things LASIK. And to get things rolling, I will just share the results. This is the first time being shared the results of our internal survey. So I surveyed the doctors at Vance Thompson Vision. We had 27 of our docs reply to this survey. 21 of them had refractive error. Of the 21 that had refractive error, 14...
Do you want me to drum roll? Drum roll? Yeah.
All right. 14 of them had refractive procedures. 9 had LASIK, 2 had ICLs, 3 had PRK, and 1 has already had an RLE, a refractive lens exchange. 100% of the people that had a refractive procedure said that they would have it again. 100% of the doctors would recommend a refractive procedure to a family member, assuming they were a good candidate. What about the 7 that have refractive error, that have not had a refractive procedure? A speckling of answers. A couple of them are hyperopes that still see excellent without any corrective error. We had a little bit of early keratoconus, a little bit of dry eye symptoms, and then what was the other one? That's it, dry eye. Dry eye and keratoconus are kind of the medical reasons. So otherwise, everybody else, if they were good, essentially, if you're a good candidate, our doctors, would have LASIK or a refractive procedure or would recommend it to a family member. And this kind of aligns with a study that was done that showed, they surveyed a bunch of different eye doctors, and a lot of them at a higher rate than, the people in the community were getting LASIK and also were recommending LASIK to family members. Doug, Dan, have you guys had LASIK, PRK, refractive surgery at all?
I had LASIK done December 23rd of 1996, believe it or not. So it'll be 28 years ago on this December. So I was a 650 in one eye, 6 1/4 in the other eye. We were in the FDA clinical trials of PRK and LASIK up until it was FDA approved in October of 95. It was approved up to 6. I was a half a diopter and a quarter diopter more than that. And so I had to decide whether I wanted to do anything at that time or wait until we got expanded parameters. So I waited an extra year and then had it done. Blade microkeratome, and been 2015 ever since. I was 32 at the time. I'm 6'0" now, and I still have great 2015 distance vision, but I can't see a lick up close and need readers. So.
And I had PRK. I don't remember the date. I barely remember the year, but it feels like a long time ago. And I had a high prescription, thin residual stromal bed. So we went with PRK as opposed to LASIK. And I had a little too much astigmatism for an ICL back then. So I went with a PRK, and I've been doing really good. Other than the first 36 hours where I complained to my then girlfriend a lot. It's been amazing.
I love it. I love it. I love it. All right. So let's, I love that. We're believers in what we're doing, which I think makes a lot of sense and probably why we're doing it. So let's kind of get into the meat of this. When we have patients in the door, that's interesting, Dan, you had PRK, Doug, you had LASIK. In that survey, we saw folks ICL, someone had an RLE. We have a lot of different hammers at Vance Thompson Vision. We have all of the hammers at Vance Thompson Vision. So what's a good patient for LASIK for you guys? Someone that's coming in, who are you going to recommend LASIK versus some of the other refractive procedures, or maybe recommend nothing? Doug, do you want to start off?
Sure, you betcha. So my favorite LASIK candidates are those that are in their 20s to 30s. They have moderate refractive error, and I'm real comfortable. Myopia, hyperopia, astigmatism. I tend to get a little bit more uncomfortable as you go up into higher amounts of hyperopia, because I really do think that there are some limits that your cornea runs into as you steepen it, probably more so than when you flatten it from an optical standpoint. And so I think sometimes people lose a little bit of their optical clarity when you really push it towards those extremes. But everybody pays attention to corneal thickness more so than they do corneal curvature. But I like those. I think because we have such good technology in the implant world, both from a phakic IOLs and refractive lens exchanges with the technology that we have now, I don't think that you really need to push either PRK or LASIK anymore. I think the options are there with going inside the eye and doing lens-based surgeries for people who are pushing those upper limits. So I love staying within the parameters of LASIK and not really pushing the cornea one way or the other. Too flat, too steep, too thin. You stay in that range, you're good. The diagnostic equipment now is so good at being able to help us determine those patients who really shouldn't have a flat made on their cornea or shouldn't have laser done to their cornea. And of course, we'll probably get into this a little bit of how much we prepare these patients beforehand from a dry eye standpoint and everything else. But that's my perfect LASIK candidate.
Yeah, and I love it. You know, everybody's not a nail to us. And to that point, one of the nurses I work with, she's actually a +5. And of course, she was undercorrected. She's wearing +3 contacts, so she's accommodating quite a bit. We marched her down. And at the end of the day, I said, "Hey, do you mind your contacts?" And she's like, "Oh yeah, I don't mind it." And I was like, I think contacts are probably your best option at this age, being a +5, +5.5 with some astigmatism. And so, you know, I think when that early presbyopia sets in, I think slam dunk RLE. How young are you going for RLE in those high hyperopes?
Yeah, I think high hyperopes are really the hardest patient group for, myope, really, we have such great options if they're not a candidate for LASIK or PRK because you're worried about corneal flattening, which, I've gotten a little bit even more conservative on what their residual Ks are because ICLs have gotten so good and we have toric options and we don't have to do a PI anymore. And so offering a ICL to really any myope is under 45 is really pretty doable. And so like if you're a myope under 45, we've got a great option for you. If you're a +3 or greater, then it gets a little bit tricky. If you're young, if you're for me, it's really below 35. I'm really nervous about it. If you're a +8 and you're 38, which I've done, I think those patients can be really, really happy if you do an RLE on them. They usually have got a very short eye. Their retina is nice and healthy. They're at low risk for, a retinal detachment with a short eye like that. I think those like +8s, +9s can do well with an RLE, but it's really at 35 is kind of when I start talking RLE. I haven't done one below 35. Doug, what are your thoughts?
I'm about right in there. I'm somewhere in that 35 to 40 range, and the reason is because they can accommodate so well, and they have their whole lifetime that it's really hard to push that extra amount of hyperopia. That I get really nervous with those 354 diopter hyperopes that are in their early to mid 30s because it's just you're steeping their cornea up quite a bit. They really haven't experienced any presbyopic like factors, but you take a 39-year-old who's a +6, it's almost like they're presbyopic. They struggle at that level, and so it's much easier to go in and do a lens exchange, and they really feel the benefits of it. So yeah, it's those hyperopes. I like that idea of about 35 in those moderate myopes, and I kind of tell them you need to exhaust your There's so many good contact lens options also now with sclerals and everything, so that can be comfortable. So then I say to them, you need to exhaust your options contact lens wise first if you're a young moderate hyperope, and then if you exhaust those options and you get into your late 30s or early 40s. Then there's a great option for you that's going to take care of you the rest of your life.
Yeah, I love that. That's probably where I land too. Mid-30s, pretty comfortable with that. And then also, it's a few things to factor in here. How hyperopic are they? Are they struggling with early presbyopia because they're, been accommodating for diopters and all of that stuff? So a lot of things to consider here. But that gets into the, you know, everybody's a little bit individual, and under different circumstances, I might go younger, right? Because boy, I can't imagine putting on a pair of +8 glasses, and if you can't tolerate contact lenses for whatever reason, but so yeah, I love that. So, when I think of a good LASIK candidate, I think of one, someone who's motivated to get out of their glasses and contacts, right? And so I want to see that somebody that, is a little bothered by glasses or contacts and for whatever reason wants to get out of them. Two, I'm looking at for LASIK, we kind of narrowed down on the hyperopia. I'm pretty comfortable going up to that +3 without really thinking too much about it. And of course, we cycloplegic those patients to see, are they really a +3 or are they actually a +5 that's accommodating to a +3? But, a true +3, pretty comfortable, all the way up to about a -6 for me. Anything more than a -6, then I'm starting to think ICL, not always going with it. I still do the occasional -7 LASIK if it's the right circumstance. Maybe their Ks are steep. They got a nice thick cornea. And I think, hey, maybe I make their vision a little bit better. Or if, they have a little irregular astigmatism without any concern for ectasia, hey, maybe we could do a topo-guided treatment and give them better quality of vision with the LASIK. So I'll go up there. But, anywhere from that +3 to -6 is a pretty much slam dunk for me. And then for age-wise, that's to say I've done we've been talking. I've done RLEs down into the upper 30s, especially on those hyperopic patients. On the flip side, I've also done LASIK this year on a 53-year-old that's completely presbyopic. She said, well, I wear contacts and I'm already putting my cheaters in. I just don't tolerate my contacts anymore. And so you have the conversation about RLE and you lay everything out for them. And she ultimately went with LASIK and she loved it. And so you'll go up there, but usually I start having that lens conversation anywhere, 40 to 45 and above. I start having the conversation, and really anything above 50, and I'm looking at RLE these days, especially with the lens technology we have available.
Yeah, and with those, and I see a lot of the refractive consults for those patients in the late 40s and up to mid 50s. Like the 52-year-old example you had, and what you want to do, and a lot of times we'll do LASIK on if they have the right expectations. Sometimes they have the expectation that they want to eliminate glasses completely, and I said, LASIK's not going to do that for you more than likely, but unless you're really good at monovision. But then you also have to plan to make sure you're not doing a whole ton of LASIK on their cornea and, like a 6.5 or 7 diopter LASIK at a 52-year-old, where you're saying, 6-7 years down the road, you're going to be dealing with cataract surgery. And are you going to limit what your options are as far as a diffractive multifocal down the road and things like that? So that's a tough discussion sometimes with those late 40s and early 50-year-olds. But on the flip side of that, I also like sometimes you have young patients. I see 38, 40-year-old patients that I think are, they're moderate myopes, maybe 4 diopter myopes that are really good candidates in everything that you look at, but they've bonked out of contact lenses. They've been going down every dry eye treatment known to man to try to get themselves comfortable, and they can't wear contacts anymore, and they're in glasses, and they want to know what's the best thing I can do to correct my vision. And kind of the last thing I'm thinking is, I don't really want to do LASIK on you. And the nice thing is the ICL comes down to a -3. So you can have sometimes what would appear maybe to be a moderate myope that would be a good LASIK candidate, but we might even do an implant on that patient just so we don't increase the level of dryness and make it more difficult for them afterwards. So it's nice that these technologies now overlap each other so much so that you have those options there.
Love that, Doug. And yeah, I am thinking, on anybody, but especially that, 40-year-old patient that comes in, hey, I'm going to be doing your lens surgery here in the next 10 to 20 years, and I don't want to burn any bridges if I don't have to. So, all right, we're going to move on. We're going to talk about now what we do to prep a patient for LASIK. And so when a patient comes in the doors at Vance Thompson Vision, Dan, what sort of testing are we getting? What's your standard refractive surgery or new refractive consult look like here?
Yeah, I think there's a whole bunch of testing that we do. One thing that I really want to focus on that we've been using a lot more is epithelial mapping.
Oh, yeah.
I think, and we can talk more about some of the other tests that are really should be standard, pentacam or some sort of corneal tomography, in my opinion, is standard now. Like you can't do LASIK without doing tomography. I think some of the dry eye testing we're doing is also really important, but epi mapping.
And I'm gonna pause you. Can you differentiate topography, tomography, and why tomography specifically is important?
Yeah, I think tomography is more important because it gives us a view of the back side of the cornea, and the back side of the cornea is where a lot of the early keratoconic and ectasia changes happen. Now, some might even argue, well, the first changes actually happen in the epithelium, then it's the posterior cornea, then it's the anterior corneal curvature. And so I think that is why epithelial mapping, for a couple of reasons, has been so huge for us. If you have anyone who's on the fence, because either their anterior cornea looks a little bit steep and you say, is this an early keratoconus, or is this contact lens overwear, or is this, occult EBMD? And they look steep in an area and you get the epithelial mapping. If they're thin in the steep area, very suspicious for keratoconus or an ectatic process. And it's some studies show that that's the first thing that happens. If you have an area that there's thinning over that steep area, and that's one of the first signs of keratoconus.
Okay, quick poll. Of the three of us here, who thinks the first sign of keratoconus is a thinning epithelium? Raise your hand.
Yeah.
Who thinks it's ectasia on the posterior cornea?
For people just listening, all three of us raised our hands on epithelial thinning. So nobody else.
It's a huge point because that's why I think epithelial mapping is. I'll let you continue, but I think epithelial mapping is going to become standard of care because of that point that you just made.
Yeah,
I've got a whole slide deck of patients where because I like to pull it up. I'll pull up the Pentacam and I'll say, "Would you do LASIK on this patient? Yes or no?" And then I'll flip over the epithelial mapping, and epithelial mapping has pushed me one way or the other multiple times. It'll make me a lot more comfortable doing a LASIK procedure on inferior steepening because I see that inferior epithelium is thick. So if I see that, why would we do LASIK? Why not just be safe and do PRK? Well, that inferior epithelium that's thick, if we wipe that away and do PRK, they're not going to be happy because it's going to grow back a little bit more uniform. Now we've treated astigmatism that's no longer there. Now we're doing a fine tune, and a PRK fine tune is not fun. And so there's a lot that goes into that. And then on the flip side, I've seen patients that actually look pretty good. Maybe the Pentacam, it doesn't look bad. And before I had epithelial mapping, I would have done LASIK. But boy, I get that epithelial map, and it's actually 45 or 40 over that cone, and it's maybe a light PRK, maybe we're monitoring kind of a situation. And so it's pushed me both ways.
Yeah, that's a good point, Brennan. Really, we rule in people just as often as we rule them out, and both are important. We have people who get sent to us that have said, "Oh, you have keratoconus, they should be cross-linked." And we look at their epithelial mapping and it's not keratoconus, it's thickening. So I think that's really how we kind of can screen for ectasia and things like that. Doug, how else are you using epi mapping, so we can screen people in, we can screen people out. How else is it helpful to you?
The other way I'm using it is I'm using it a lot more. I know we're talking mainly about LASIK, but LASIK applies when we're thinking about doing enhancements or fine tunes on advanced cataract patients after their cataract surgery. And so I'm starting to work up the cataract patients that are opting for a diffractive multifocal implant. If we're going to have to do possibly a corneal fine tune on them because we don't hit the target, then I want to make sure that epi mapping and corneal thickness and curvature and everything and dry eye wise, that I'm okay with them having a corneal fine tune afterwards if we're not going with the light adjustable lens. And maybe then I might even find something that's a reason for me to switch in that decision of which IOL we're going to choose with the cataract. So I'm using it in our cataract patients. I'm also using it in our enhancement decisions. So I'll have, we had a patient here a few weeks ago, had LASIK done almost 8 or 9 months ago, pretty moderate myope, 5-diopter myope or something, came back in. I think they were maybe a year out. And right eye was 20/20, 20/15, left eye was 20/30, refracted at a -1, and young 32-year-old couldn't figure out why one eye was all of a sudden undercorrected, because he said he started out pretty good. Did an epithelial mapping, and his epithelium was like 68 in his that left eye, and in the right eye was like 52. And so he had an epithelial hyperplasia in one eye, and that was the epithelium that had caused that. And so eventually we may be able to go in and fine tune him, but if you had just come back and said, oh, I think we'll just do a fine tune, and you didn't know the reason why that was happening, I'm using it a lot of times for enhancement decisions now also.
Yeah, especially a PRK fine tune. I had a buddy
Yes.
tell me
Yep.
this week. He said, "Hey, man, I had a patient. He had LASIK a few years ago. He regressed back to a -1. He's like, I'm really leaning towards doing a PRK fine tune." And I said, "Boy, can you get an EpiMap? Because if that epithelium's 65 and you're going to do PRK and it comes back 50, he's going to be unhappy for the next year and a half to 3 years for the epithelium to hypertrophy." So I said, you better so I said, number one, you need to get an EpiMap on that to decide if you're going to, lift the flap or if you can get away with a little PRK. But
And
yeah,
the epithelium
okay, so
might not have hyperplasia the second time. That's why it's unpredictable.
Right. You don't know.
So if you would just have treated the epi, you might have got him back to plano. If you'd have treated the epi plus ablated him, you probably would have left him a +1 or something. And then he's, like you said, unhappy. And so I think it's really, really been a key part of our change. Maybe, and then I think we're doing a lot of dry eye testing that is so important. And the reason is, there's a lot of studies now that have shown, even in patients who are asymptomatic, putting them on an anti-inflammatory like a cyclosporin, in addition to the steroids before and after the surgery, really can help with some of those symptoms. I mean, Doug, what are kind of some of the things you're doing every day for dry eye treatment for LASIK, and how are you working them up?
We're working them up. We're doing mammography on them, on most all of our refractive patients. I want to know what their meibomian glands are doing. At the slit lamp, you're looking at their lids, pushing, pulling, squeezing. I'm doing all that, like a full workup for a dry eye patient when I'm thinking LASIK. As I'm sitting at the slit lamp, I ask them, are your eyes normally pretty comfortable? So I have 3 questions I ask them, and most of the time it's at the slit lamp, and it's to help me with all the rest of these tests that I'm doing. As I'm at the slit lamp, I'm saying, are your eyes normally pretty comfortable? And they're going to tell me whether they're have dry eye symptoms or not, or they're comfortable or not. Second, do you rub your eyes, or do you sleep with your face in your pillow? So then I know whether there's any mechanical thing that they're doing that could affect that epithelium or affect their flap or their cornea long term. And if they're rubbing their eyes, then we have a discussion about that. And then third, those patients that fall into the late 40s to early 50s, my third question is, how's your nighttime vision? It's the poor man's glare test. And so it gives me some information about how much are they bothered by any scattered light, because then I have a little bit of an approximation from their perspective of what their lens is doing to them. And then we're doing all of the dry eye testing. I do a lot of punctal plugs. We do a lot of meibomian gland treatment. We do a ton of immunomodulators, whether it be cyclosporin or lifitegrast. We're doing a lot of that treatment preoperatively for patients with LASIK, and I don't think you can over treat anybody prior to their LASIK. And I have a lot of patients who have no symptoms and don't measure very much, and I'm still being fairly aggressive at treating their tears. Use a lot of temporary collagen plugs day of LASIK just to give them an extra 3 to 5 weeks of extra tears. We do a lot of that as well.
Yeah. Yeah, and I'm usually, having the conversation with the patient too. Usually my conversation about dryness, this I, tell every LASIK or tell any LASIK or refractive surgery patient, I say, hey, dry eyes after any eye surgery is not uncommon. Okay, it's pretty normal. We know, because dry eye after LASIK is one of the most studied things. And I say, dry eye after LASIK is real. And the other thing we know is, in the vast, vast majority of patients, it's temporary. Now, everybody heals differently. Whether it's 3 days, 3 weeks, 3 months, it's a little bit different. But generally that dryness goes away. And if not, we can treat it. but chronic dry eye after LASIK is something that we don't see a ton of. Um,
Especially
and
if they've been properly screened and they don't have
exactly,
pre-existing, maybe
exactly.
that's very good. If they don't have pre-existing dryness that was missed, it's really uncommon to have de novo permanent dry eye disease after having a, normal LASIK surgery.
All right, so last thing I'll touch on the before, and then we'll transition to the after. But the before, the other thing that we do is see and do LASIK. So see and do LASIK is where we live in a geographically spaced out part of the world, right? And so we'll get patients that drive 3, 4, 5, 6 hours to have LASIK or refractive surgery with us, and we trust the eye docs out in the community to make these good referrals on folks who want LASIK. And so a see and do LASIK is where we get a good referral in from a doc. And I think the most important piece of that is being cyclopleged with cyclogel or cyclopenolate, so a true cycloplegic refraction. And then we can call and talk to the patient beforehand. And then we do a LASIK consult that morning and usually do LASIK later that day or that afternoon. And so we can kind of bunch everything up together. And that just helps out folks, instead of making 2 4-hour trips, they can make 1. And in those patients, I've canceled see and do surgery before, right? And so we're not afraid to stop the momentum on those things. And so it's a great way to take care of our community. All right, transitioning. We talked about the before. Let's talk about the after. Dan, what is your routine aftercare for LASIK?
Yeah, I have a hair trigger. So typically we do a combination drop that we use 4 times a day for a week and then 2 times a day for 3 weeks afterwards. And that combination
just to clarify, combo drop is a steroid, the one we use for LASIK, typically steroid antibiotic.
Correct. Steroid antibiotic, and usually it's a fluoroquinolone is the most commonly used. They're really well tolerated, great on the ocular surface. Not a ton of interaction with MMP, the MMPs. There is some interaction, but very little. So it's great for the ocular surface typically. Oftentimes they can be non-preserved also, but we use it in 1 drop, so it's really easy for the patient. And we typically don't do any NSAIDs or anything like that for our LASIK patients. Now for PRK, sometimes we'll use it for patients who have pain. But for LASIK, we're typically doing that. And then I have a hair trigger for adding an immunomodulator like cyclosporin, especially any sort of symptoms that they have. I'll do it for a month before LASIK and a month after, sometimes 3 months after. And it's just to get them through that temporary dry, or it's really not even dry eye. It's that ocular surface healing that has to happen after a surgery. And there's been a lot of studies that have shown that helps. And then, like Doug mentioned, temporary punctal plugs. Usually I do that at 1 week if they have any sort of staining, but sometimes I'll do it before. But typically at 1 week, if they have any sort of staining, I'll just pop those collagen plugs in there to get them through that first 60 days or so of toughness. So that's typically what I do. And like you said, with the see and do process, it's really easy for people to come and do that one really important vision trip of their lifetime, where this is their one chance to do this. They want it done right, and then we can do that aftercare with their doc close to home.
Love it. Doug, what's your typical follow-up rhythm? Most of these patients are seeing their primary eye doctor afterwards, but what do you recommend for following these? What's your frequency or interval?
Our interval is at 1 day post-surgery. Then we go out to 1 month, and then I'll do a 3 month. And then at the 3 month, I'll just have the discussion with the patient, depending on how they're doing. I'll say, I want to see you one more time, whether that would be a 6 month check or whether you want to just move it all the way to a year. And that's kind of what I tell the docs that we work with out there. You can be the judge if you want to push that 3 month out to your just annual eye exam if you want to. And so sometimes I'll just push them out to that and say, we're here, we're just a phone call away if you need us. They're 3 months out, they're 2015 uncorrected, they're happy with everything and really comfortable. Then I tell them there's probably not going to be a lot of change. Although from 3 to 6 months, a lot of people with LASIK still feel like they got an improvement in their sharpness and clarity, certainly true for PRK patients. And so they may get a little bit sharper and clearer. And maybe they might say, well, can I just come back at 6 months just to check and make sure everything's fine? I'm completely fine with that. And then move it out to the full year. We used to do a week check, and we kind of let that go. The week checks were really not doing a whole lot for the patients. They, we give them really, really good instructions, and when they're with their co-managing doc out there, they've got really good instructions. They've got the access, so they know if there's anything that they're concerned about, what to look for, then give us a call or their co-managing doc, and they can see them at a week if they need to. But generally, that gives them a chance to get off those medicated drops and kind of settle in and recover by the next time we're seeing them. And then we can really help them with, okay, here's what's going to happen over the next several months.
Yeah, it's interesting, Doug. We did a big study here looking at topo-guided LASIK, and when you look at the FDA data from 3 months to a year, there was statistically significant improvement in those patients' vision with topo-guided LASIK. Is that cornea regularizes, and the epithelium then regularizes back to what it should be after you've taken care of any irregularity. So it is really surprisingly not that uncommon for people to get better from 3 months on, even if they're not really happy. And that's why, being a little bit of patient on an enhancement and not rushing into it is sometimes a good idea, especially if they've got minimal refraction and are just really saying, it's just not as quite as sharp as I would like. So,
and I guess the last thing I'll throw in there on these follow-ups, because most of them are being done out in the community. The ones that aren't being done out in the community are our research patients, because if we have a research trial going on, which we frequently do a lot of, Vance himself was involved with the initial laser trials for PRK and LASIK. Doug, you too. And so, typically when a laser gets FDA approved in this country, we're one of the sites that's running the trial. Same with ICL or implantable lenses as well. Those follow-ups are being done in-house, because how the FDA works is they have to have a site monitor, and they have to actually come and sign off on all of the equipment. They have to actually come in for routine checks while we're actively enrolling and following up for these studies. And so it's a very tightly regulated process. And so for that reason, study patients are coming back and we have to follow them in-house. But
some of the protocols have relaxed a little bit. That's one of some of the earlier clinical trials. It was all had to be done at the research center that did the procedure, but some of the clinical trials allow for the co-managing doc to do some of those visits, and then the research has to follow them at certain intervals. So sometimes the co-managing doc gets to get involved in those research protocols too, and kind of seeing where their patient was randomized to and stuff like that, which is kind of fun. So for them to see.
All right, last thing I think we'll touch on, and maybe only a couple minutes here, but I think probably the biggest two things are for LASIK follow-up. What things are you looking for? Now, if you're, to the community docs listening that are doing these follow-ups for LASIK, what are you really looking for on that post-op day one visit?
I'm concentrating on how their flap looks at day one. And so we're in our in-house here, we have some surgeons who do flap checks right afterwards, some who don't. But that 1 day visit is to make sure that the flap is where it should be, that there's no excessive inflammation. There's no, the femtosecond laser, when it makes the flap, also makes a little vent superior to let some of the gas bubbles that the laser creates out. And sometimes people who've worn contacts for many years, of course, they have a little bit of superior neo. That laser hits that, and there's a little bit of heme built up there. And sometimes that'll trickle down into the flap or is spread out along there. And if it's pretty significant, we might want to see that patient back to rinse that out, just because they might have an immune reaction that might trigger some inflammation. And so I'm checking the flap itself. With laser made flaps, you can check the gutter of the flap very easily and make sure that it's even all the way around, even at 1 day. And you can look at the interface of the flap and you can see if it's clear, it's smooth. You can see any microstria or irregularities that are there. And then make sure that what you are seeing in the slit lamp matches with what your patient is saying and what they're measuring on the chart. Okay. And then if all of that is looking good, then you're okay to let them go for probably 3 weeks until you see them again, and make sure they're following their instructions. So that's really what I'm concentrating on day one.
I love that. Yeah, the things I'm rinsing out on day one, because I would say like the big thing is to decide if you're going to do something differently. And so I think there's two things I will potentially do differently. If I see some white blood cell, so the patient's a little photophobic, there's some white blood cell recruitment. Maybe it's from an early DLK, whatever's causing that, little staph marginal or a little epithelial defect or whatever it is, we can bump the steroids up. And most of the time, a stage 1, stage 2 DLK, you bump up prednisolone and it'll just go away, you know? But if it gets a little bit, if it gets to that stage 3, maybe stage 4, and things aren't turning a corner, we're rinsing on day 1, 2, or 3, but I'm following those patients closely. So I'm making the decision on, do they need a post-op day 2 now? Are we increasing drops or not? And then, the flap lift rinse. If there's, if a fiber snuck under the flap, red blood cells, I'm often not rinsing out, assuming it's not causing a DLK. Also, if it's not in the visual, if they're 20/50 from a little bit of heme that snuck into the vision, it's pretty easy for me just to rinse that flap out and get them better vision right away. It probably fades. It will fade with time. But I'm often rinsing those just so those patients are happier quicker. I'm not rinsing any meibum. Meibum gets under the flap, not uncommonly. That's not visually significant. It usually doesn't cause any inflammation. And so, so that's one thing I'm doing. The other thing I think on the follow-up is we're deciding for a fine tune. Dan, what's your decision, post-op day 1, post-op week 1? When are you pulling the trigger on potentially doing a fine tune?
Yeah, kind of like we talked about earlier, it's not until 3 months. I want their cornea to, and preferably later, but like 3 months at the earliest, because I really want to have that cornea regularized. Their dryness should mostly be gone by then. And so I am waiting for things to regularize. I want to repeat epi mapping. Hey, did they just have a bunch of hyperplasia of the epi, and is that going to settle back down? What's happening with that? And so I think you can easily lift the flap within the first year for a fine tune. Going out past a year, it gets still very doable. But, if I'm going to fine tune someone, it's usually in the 9 to 12 months after surgery is kind of that time period. I think is kind of a nice sweet spot where their refraction's stable. It hasn't been too long that the lift flap should go pretty smoothly.
Yeah, and I generally talking about it at the 3-month visit. Yep. We call our patients at that 90 to 100 days. How are they seeing and all of that? We get them in for an eval if they feel like they aren't seeing as good as they'd like to. And I'm usually measuring. If it's a plus a quarter minus a half refraction, we're kind of, talking about, hey, we don't want to chase our tail with a laser. Let's see if we can optimize the surface a little bit. If they're sitting at, if they have a little bit of surprise astigmatism or anything like that, then I'm really saying, okay, let's schedule a see and do. Let's cycloplegia today. Let's schedule a see and do in a month from now. And if the refraction's stable, we'll pull the trigger. If it's changed a little bit, maybe we pause again. And so that's kind of my routine. But yeah, I agree. The further you wait, the better. And we just don't want patients to get, too frustrated also on the same end. So, I've had that -2.5 engineer that came in, and he came in, at 4 or 5 months, and he was -1/4. And, he's like, golly, did I do it? Absolutely, I did it. I did it. And he called us a week later and he said, this is why I came to you. This is why I drove 3 hours down to you guys, because I knew you'd take the best care of me. And you heard me, I was 20/20 unhappy. My other eye was better than 20/15, and I was 20/20 unhappy with this other eye. And I noticed it because I'm an engineer, and we fine-tuned him and he loved it. So, and that's where it's just listening to the patient. Every patient's a little bit different.
I agree. I like saying it that I start the conversation about a fine tune at 3 months and reassure the patient that even if they're unhappy or didn't not where their expectations were, that we're starting the conversation now because I'm letting you know that you're correctable, which means you're fine tunable. Now we just have to make sure that it's stable and then get them to go that next 3 months or 6 months or whatever to make sure you've got the stable measurements and make sure that there's a chance that they might not improve on their own. And so I started at 3 months. Earliest we probably fine tune is 6 months, and depending on Now we bring in epi mapping and some of those other things. We may be waiting a little bit longer as that cornea might normalize a little bit, especially in those small residual refractive errors. And it's pretty rare that you have a big residual refractive error after a LASIK now. I mean, we don't miss it by a ton very much. So you're usually dealing with pretty small refractive error, which makes a tougher decision most of the time.
All right, guys, all good thoughts. I think we're going to wrap this sucker up. Any other closing thoughts on LASIK? I mean, we're still doing a lot of LASIK these days. I mean, it's a great option. Again, we said not the best option for everybody. It starts with, a little motivation to get out of glasses, contacts. But any other closing thoughts on LASIK?
I think LASIK's in probably the best space it's ever been in the last 30 years. And the reason is because all of the other technologies have allowed us to not have to push LASIK. And I've been through all of the technologies from the early MKM and RK days all the way up through. And now the nice thing is LASIK doesn't ever have to be pushed to its limits. You can settle in with LASIK and PRK in these wonderful patients that are moderate myopes and hyperopes and astigmats, and you just get these wonderful results. And then anybody that falls outside that range, look at all this cool technology we got that can correct them and not have to push them. And so I think it's in a beautiful place right now. So.
Love it.
Well said, Doug. Thanks, guys.